Okay. Can you hear me? So, welcome to our special program today. So, we have a very special guest speaker, Mr. Jehan Bista. So, he is actually a college student, okay, third year college student, and he is planning to go to medical school. And he did emergency medical system training in the United States, okay, so that he can have a feel about medical system. So he is going to give a talk about EMS in the United States. And we also have second speaker who is very well known to you, our Dr. Sisti. She is going to talk about an update in ventilator management in ARDS. This is critical care update. So the other interesting thing is we have another guest with us, Dr. Bista. And some of you know him very well. He was the second FCPS from Bangladesh. And after FCPS, he joined Patan Hospital back in 90s. He used to work in Department of Medicine. And after that, he went to the United States. And now he is practicing as a nephrologist in Arizona. And Jehan is his son. And we have another nephrologist with us who is also practicing in the United States, with Dr. Arun Amate. So welcome, let's welcome all of them. So let's welcome Jehan for his presentation.
Thank you for the introduction. Appreciate it. So my name is Jehan. I live in the U.S. and like you said, I'm a college student, so not yet a medical student, but hopefully someday I can get to that level and be just like you guys. So I'll be talking about the EMS system, and I've been in Nepal for a few weeks now. I've been staying in Anandavan, up there in the leprosy mission hospital, so it's been really fruitful, and I've got to see surgeries and do a lot of interesting things. So the evolution of EMS started back in the late 1700s with Napoleon's army. Back then, his surgeon, his main military surgeon, his name was Jehan, and he developed a system of triage, which we now know is treating patients based on the severity of their symptoms. So back then, when you would see just bodies scattered around in the battlefield, you wouldn't know who to treat first and who to treat second. So now we treat them based on the severity of their symptoms. And starting from the Civil War era, we started implementing this triage and pre-hospital care system in our own battlefields and doing the same things that Napoleon's army did. Once we got into the 1920s, we had volunteer rescue squads. We started them in Virginia and New Jersey, and we started developing this pre-hospital care system and ambulance and whatnot. Once we get into the 1960s, Dr. Safar from Austria developed this system of CPR. First, it was mouth-to-mouth resuscitation, but now we know that CPR is more effective using chest compressions because you get more oxygen. So for pre-1966 EMS system in the U.S. was very disorganized. We had very poorly trained technicians who didn't really know what they were doing. The ambulance drivers oftentimes weren't trained, didn't know where they were going half of the time. There was very minimal equipment, and there was no physician involvement. Nowadays, we have something called a medical director who actually oversees the EMS affairs on a local level, which I'll get to later. And there's no radio communication, so we wouldn't have a dispatcher telling us where to go. We wouldn't be able to communicate with law enforcement officials. Things were just very, very disorganized, and there was no systematic approach. You might do something 3 different times for the same procedure. So once we got to So in 1966, we have the white paper. So this is a very influential paper that was written by the National Academy of Sciences that pretty much said the system that's going on right now isn't effective, and we need to do something better and implement things on the national level. So it exposed deficiencies in emergency care. It told us, the ambulance are ill-equipped and they aren't properly designed in order to house the patients and whatnot. So after 1966, after this paper was established, we established the National Highway Traffic Safety Administration, which basically oversees EMS affairs on a national level. So there's a couple different components here. So regulation and policy, obviously, they regulate EMS affairs. Resource management, we want to make sure that we have enough resources in order to facilitate the system. Next, we have human resources and training. So we want to make sure we have enough paramedics, we have enough EMTs to go in certain areas. We want to make sure we have the right sort of transportation, so the ambulances are well equipped, that they're structured properly. We want to make sure we have adequate facilities, obviously. Communication, so we want to make sure nowadays we communicate very well with law enforcement officials, with firefighters, with the hospital, the trauma centers. So nowadays the communication is very efficient and works very well. Next, we have public information and education, which I'll get to later, but now there's a bigger push for public education and information, because before, you would have doctors treating you, or we'd be treating them, but they wouldn't really know what the procedures were or what we were doing to them. So I'll get more into that later. The same with medical direction. I'll get more into that later. And trauma systems, so we want to make sure when to figure out if you have a major or minor trauma patient, and when to send them to appropriate trauma facilities, because trauma facilities range from level 1 to level 4 depending on the severity of their symptoms. And lastly, we have evaluation, which I'll get to later also, but evaluation is basically saying, like, what are we doing right, what are we not doing right, so what are ways that we can improve the system. So this is our EMS logo that we established after the white paper. So this is our Star of Life, and there's 6 main components here. So first is early detection, so we want to make sure that whenever we see a problem arise, that we can detect it as early as possible, because the earlier you detect a problem, the earlier you can fix it. Next is early reporting, so we want to make sure that our dispatchers and stuff, whenever they hear the information, they report it to us as soon as possible. And also for us, when we're reporting to the hospital, we tell them that, hey, we have a patient in serious or critical condition, so make sure that they're ready also when we get on the scene. Early response, so we want to make sure that we respond to situations in a timely manner, that we're not disorganized, and that we get to the scene on time. On-scene care, we want to make sure that we act in a very professional way, that we know what we're doing, and that when we get on scene, we have all of our equipment. You have a patient with hypoxia or something, we want to make sure we have our oxygen tanks ready and that they're full, and we have our OPA and PA, all these different tools that we need to use. So next is care in transit, so we want to make sure that while they're in the ambulance, we're also treating them. For critical patients, we evaluate them every 5 minutes, for non-critical every 15 minutes. And then transfer to definitive care. So you want to keep cognizant of the fact that different patients may have to go to different locations. Maybe because all the time you might not have to go to the hospital. So let's say you have a patient who's poisoned and the hospital doesn't have the anti-venom. So you might have to go to a local poison center. You have a trauma patient, they have to go to a trauma center. They couldn't go to a hospital. So you have to keep these things in mind also. And then this snake in the middle is just kind of like, this is the rod of Asclepius, so this is like an ancient Greek symbol of healing that we just kind of stole and put on. So next are links in the EMS system. So there's 5 different main components. There's detection and access, like I mentioned earlier. You want to make sure you detect the problem as soon as possible, and you have access to paramedics and EMTs and different people to take care of you on scene. Next is dispatch and response. And next is BLS, so that's your basic life support. That's what we do as EMTs. ALS is advanced life support, so those are your paramedics and whatnot. And then you have your emergency department where we send them off. So your emergency medical dispatcher is fundamental in the EMS system, because what they do is they tell you all the relevant information you need to know before you actually get onto the scene. So they tell you things like, oh, if patient so-and-so was shot, or so-and-so was poisoned, or in so-and-so location. So they tell you relevant piece of information that you need to know, and you need to make sure that the scene is safe. So this is what the dispatcher is for. Oftentimes, dispatchers aren't EMTs. Oftentimes, they're just solely dispatchers, but they can or may not be EMTs as well. So. Next, you have us, so we have emergency medical technicians, so I'll get more into what we do later on. Advanced life support, so you have your paramedics, so they do everything we do, but they can also do advanced airway maneuvers like ET intubation, they can read EKGs, and they can do IVs and all these things that we can't do. Then lastly, the emergency department is where you want to give off the patient. One thing to be cognizant of is the fact that when you're handing off a patient, you always want to give it to someone of equal or higher medical understanding. So if you're an EMT, I would want to give it to a paramedic or to the physician at the emergency department. Oftentimes, what happens is when you go onto the scene, you get to the hospital. You're very busy. You have other calls, so you just kind of give it off to the secretary, or you just give it off to someone at the front desk, and they don't necessarily have the same level of medical training that you do. So you need to be cognizant of that because you could get into legal issues. It's known as negligence when you don't treat the patient. So national levels of training here, we start with the first responder, EMR. EMR stands for Emergency Medical Responder. So what they do is help us at the scene of the incident. Oftentimes, they just know basic things like basic CPR or first aid or things like that. EMRs could be law enforcement officials or firefighters, things of that sort. Then you have your basic EMTs, so what we do. And then you have, in some areas of the country, you might have AEMTs. So these are advanced EMTs who know what we do, but kind of can do a few more things like IVs and things of that nature, because in some states, there might not be as many resources, because in the big cities, you will have your paramedics, your EMTs, your firefighters all showing up at the scene of the crime. So when you have, when you're in very rural areas or kind of in the middle of nowhere, you might not necessarily have paramedics around. So you want AEMTs to be there at the scene of the crime, or the scene of the incident. Next, we go to components of the EMS system. So what exactly constitutes our system? So first, we have public access, so we want to make sure that all the information that we know is also accessible to the public, because we want to make sure that they're also educated and that they know what we're doing to them. So anytime we do a procedure, we'll tell them, oh, we'll be doing this, this, and this to you. Well, assuming they're conscious, we can tell them what we'll be doing. Next is communication systems. So I mentioned before, we just want to make sure we communicate well with others. Clinical care, so we want to make sure that we always put the patient first and that we treat them in a very professional manner. Human resources, I mentioned. Medical direction, I'll get to. Legislation and regulations, so you want to make sure that we have people who are overseeing the system and making sure that everything is going well. Integration of health services, so we want to make sure that as EMTs, we have affiliations with local hospitals and trauma centers and whatnot, so that they know when we're coming, so that they're not surprised when we show up on the scene. And next is evaluation. So we have these things called CQIs, or continuous quality improvement, which I'll get to later, but it's kind of a way to review the system and reevaluate the system. Next is information systems and finance. We want to make sure we have enough money and that all of our patient information is confidential and things of that nature. Because we have like HIPAA laws nowadays, so we want to make sure that there's always confidentiality for the patient. And then education systems, we want to make sure that we continue our education in a very professional manner, that we have different schools and classes and programs in order to teach new EMTs, and that we have, that it's always like a continuous learning system. You always have to learn. And every 2 years as EMTs, we actually have to retake our course to make sure that we actually know what we're doing, that we haven't forgotten anything. Prevention, public education, and research I'll get to. So overview of our local EMS system. I live in California, so in Los Angeles County, we generally have an engine and rescue ambulance. But in the county itself, we have an engine, a rescue squad, and an ambulance. And it's a paramedic-based system, which means that even if you like stub your toe or something and you call 911, you will have paramedics, EMTs, and firefighters all showing up on the scene, even if it's something very minor. So we're very blessed because we have a lot of resources in our city. Roles and responsibilities of the EMT. So first of all, we want to make sure that we're safe, because if we're not safe, then we can't treat others. We, next to our safety, we want to make sure that our partner is safe, because every time we go onto the scene, it's you and your partner. There's always two people showing up. You want to make sure that the patient's safe and that the public's safe. Public safety obviously comes before patient safety. Even if patient is critical condition, you don't want to, as an ambulance driver, you don't want to swerve through traffic and put other people in danger just for the sake of more money. Next is patient assessment. So we want to make sure that when we get onto the scene, we can look for certain things for the patient. So I'll get more on the patient assessment later. Patient care based on the assessment findings. So based on what we find, we give them proper treatment. And then lifting and moving patients, transport and transfer of care, which I mentioned. Record keeping and data collection, keeping patient information confidential. And then patient rights. So we always advocate the patient first, and we always try to do the most good for the most number of patients. So next is medical direction. So medical direction, basically a medical director is a physician who's responsible for local EMS affairs. Because as EMTs, we only know so much about medicine, but you guys know a lot more than we do. So we want to make sure that we have proper guidance in, when we do certain types of procedures. And every ambulance system has to have at least one medical director. And they're also responsible for CQIs. So there's two different types of medical direction, offline and online. So online medical direction refers mostly to just calling the physician directly. So this could either be over the telephone or the radio. Maybe you see a patient and you're not exactly sure what to do, or should I assist them with this so-and-so medication? Maybe they have cardiac chest pain. You're like, oh, should I administer nitro? Maybe you call them in that situation. Next is offline. So offline are things that are all written and protocols and certain things that we as EMS professionals should all do every time. So at any time we see a certain procedure, we should do things in a certain way. It should all be the same every time. So we want to make sure that we follow online and offline procedures. Next is evaluation of the system. So CQI refers to continuous quality improvement. So these are reviews and audits of the EMS system that are performed every now and then in order to see what we're doing correctly and what are ways that we can improve the system. Because information and skills in emergency medical care change constantly, there's always new information that we're learning, and so we always want to make sure that we're always continuing education and taking refresher courses and always having meetings and whatnot, figuring out how to minimize errors in the future. Next is prevention and public education. So nowadays in the U.S., there's more of a bigger push towards preventative medicine, because we already know that the doctors, you guys know what you're doing, and we should know what we're doing, but the patients oftentimes don't really know what kind of procedures we're doing or how exactly to prevent future occurrences of certain procedures. So there's two different prevention strategies. So first is primary prevention, things like vaccinations, immunizations. We make sure that we prevent things from ever happening. So that's why we have our vaccinations and whatnot. And next is secondary prevention, which is what we're pushing towards more nowadays. So once an event has already happened, how to prevent it from happening. So nowadays in LA County, we have, after we evaluate a patient and we take care of them, 4 or 5 days later, we'll have paramedics actually go out and go to patients' houses and ask them, hey, like, how are you feeling, and assess them, make sure that they're actually better in the long term, and that that we didn't just fix them for the short term. Make sure that we are doing things for long-term benefit of the patient. Lastly, we have EMS research. So research is a very important part of the EMS system because we're constantly learning new information. So for example, in the early days of EMS, whenever we would have major trauma patients on the scene, we would try stabilizing them on scene and then bringing them to the trauma center. What we realized though is that we don't have the right kind of knowledge or expertise to actually, um, you know, help these trauma patients in any beneficial way. So nowadays what we do is we just quickly do our primary assessment, put them on the backboard and send them as quickly as we can to the trauma center. And you know, it should always be evidence-based, and we should always stay up to date on research. So next we have I wanted to kind of explain like what we do when we get on the scene for patient assessment. So first we have our scene size up, so we got on the scene BSI. We say BSI scene safety, body substance isolation. We want to make sure we have our gloves, our goggles. We want to make sure that we're good to go on scene. Next is the scene size up. So before we even get onto the scene, we're looking at for a few different things. So we use a lot of acronyms. So one of them is PENMET. So P is safety. So personal, partner, public safety. We want to make sure that I'm safe, my partner's safe, and that public safe and the patient safe. Next is E, environmental hazards. You're looking for certain environmental hazards depending on where you are. Maybe you're in a really cold area up in the mountains, so you look for things, you know, like snow and different kind of things like that. Number of patients, you want to see how many patients you have. If there are too many patients, maybe you have to call ALS or you call the hospital, let them know that there's a mass casualty event. And mechanism of injury or illness. Before you get on the scene, you generally don't know what the mechanism of injury is, but it's helpful to know because 90% of the time, the mechanism of injury will be indicative of what kind of problem the patient has. Next is additional resources. So as EMTs, additional resources would either be the hospital or ALS. So depending on how far away the hospital is or ALS, we might wait for ALS to show up on the scene, or we might go directly to the hospital. So it depends. And then N is the need for C-spine. So for big motor vehicle crashes or significant mechanisms of injury, we want to make sure that we apply a collar to the patient and stabilize their cervical spine. Next is general impressions. So as you're walking up to the patient, you can kind of see, you know, you look for generally what age they are, male, female, and any life-threatening injuries. Next is patient rapport. So you don't want to just go up to the patient and start working. Obviously, you want to go up and say, "Hi, you know, my name is Jehan. I'm an EMT. How can I assist you today?" If they're unconscious, obviously there's no patient rapport. You then determine the responsiveness of the patient. So if the patient is unconscious, and we use this thing called APU, which I'm sure you guys are familiar with, to determine how responsive they are. So either they're alert, which we can tell by, you know, are they tracking us with their eyes, or do they seem alert? Are they verbal? So do they only respond when we speak to them? Do they, if they're kind of like, you know, passed out, but we apply painful stimuli, do they wake up, or are they just unresponsive? So then, next we have our like A, B, C, D, E's. So, you know, A, airways. So we want to make sure, you know, if they're talking back to you, obviously their airway's patent. So, but if their airway isn't, you know, you would use certain tools. So maybe you have your OPAs or your NPAs and certain things like that. Suctioning is also a big one for airway. Next is breathing. So for breathing, you want to make sure that if the patient is hypoxic, you know, you want to make sure you have your oxygen tanks ready. You want to make sure that you have different sort of masks, your nasal cannulas, your BV mask, your BVM mask, so different types of things. For their breathing, you see if they're fast. You look at the depth, you look at the rate, the rhythm, the quality of the breaths. Next is circulation. So you look, you know, are they bleeding? If they're bleeding, then we would have certain types of interventions. We would apply gauze, or we would use tourniquets. We would look for their heart rhythm. So we want to make sure the heart rhythm is strong. We want to make sure that we look for skin signs. So we make sure that the skin isn't flushed or you know, isn't cyanotic. So we look at a lot of different types of things. Capillary refill is mostly for, you know, children. So we want to make sure there's less than 2 seconds time for capillary refill. Next, we look at any sort of disabilities or deformities. So we want to see, do they have any sort of, for disabilities, maybe medical alert tags, maybe broken bones, things like that. So in those kind of cases, we would apply splints, we would do different kinds of interventions. Lastly, we look at our chief complaints, so we look at what the patient is complaining about the most, and we focus our care on that. So, you know, shortness of breath, we focus mostly on, you know, cardiovascular, pulmonary issues. And lastly is transport decisions. So once we've done our primary assessment, then we can call either the hospital or ALS. We tell them that, hey, like, we have a patient in critical condition, we need a treatment. Next is secondary assessment. So our primary assessment is always the same, but our secondary assessment changes based on the severity of the patient. So if you have a responsive medical or a minor trauma patient, then it's not really a big deal to do like a full body check or anything. So we would just ask them questions. We have our sample OPQ-RST in our patient sample forms. So OPQ-RST, if they have any sort of pain, we look at the onset of the pain. Is it sudden or gradual? P, we look at palliation, or what provokes the pain, what makes it feel better, what makes it feel worse. Quality of the pain, so what kind of pain is it? Is it a sharp pain or is it a very dull pain? We look at region, radiation, reoccurrence, so where is this pain located? Does it go anywhere else? And have you had this kind of pain before? Then we look at severity on a scale of 1 to 10. How painful is it? And then the time, so how long ago did this happen? Sample, we look at different, for sample we ask them things like, so for S, signs and symptoms we should already have established. And then ample, so we look at, are you allergic to any sort of medications? Or M, what types of medications are you currently taking? For P, we look at pertinent medical history, so any previous surgeries, anything of that sort. And then L, we look at last oral intake or last exit. So when was the last time you went to the bathroom? When was the last time you ate any sort of food? And then E, events surrounding the incident. Do you remember what happened before the onset of the pain? For example, you have a patient with angina. You can tell because they did some sort of physical activity beforehand. So that's always good to know. Next, we check their vitals. So we use another acronym here called BELS-RP. So we look at different things. Blood pressure, we need to know how to look at their blood pressure. Eyes, we want to make sure that they're round, that they're reactive to light, and that both the pupils are the same size. Let's say we see pinpoint pupils, we know it's some sort of opiate poisoning or something. So we always want to be cognizant of that. Next, we look at lung sounds. So we check all the lung sounds, look for things like stridor and wheezing or cough or anything of that sort. Next, we look at respiration, so rate, effort, tidal volume, adequate rise and fall of the chest. Next, we look at the pulse, so we want to make sure that the pulse is strong. Generally, for kids, we're looking brachial, and adults, we're looking at either carotid or radial. And then we use this thing called a pulse oximeter. So pulse oximetry, basically, it counts the number of hemoglobin cells in your body in order to tell how effective your respirations are. And then for major trauma or responsive medical, we kind of do it differently. The vitals and everything we do separate. And OPQ-RST sample generally we can't do because most of the time these patients are unconscious. So there's not really much we can do. But generally we do a detailed physical exam. So we use another acronym that's not shown here called DCAT-BTLS, which stands for deformities, contusions, abrasions, punctures, penetrations, burns, lacerations, tenderness, and swelling. So we're looking at all of these things when we're doing a very thorough checkup on the patient. And also, consider all interventions, splints, tourniquets, whatnot. Lastly, we also assist with a few medications. Generally, we don't do that much, but a few things we do here. So for our hypoglycemic patients, assuming that they're responsive, able to swallow, no gag reflex, we apply oral glucose between the lips and the gum. Also for patients with severe anaphylaxis, we apply, we give them EpiPens. Now we can't just give them someone else's EpiPen. We have to make sure that we assist them with their medication. So on the EMT level, we only assist with medications. Next we have MDI, so meter dose inhalers, patients with asthma, assuming that it hasn't expired and that we can also apply that. And in patients with cardiac chest pain, we give nitro. You guys know about nitro, so just look out for, we want to make sure their blood pressure doesn't drop too low, that they haven't been taking any sexually enhancing drugs within the last 72 hours, and that they've taken their max dosage. Lastly, for poison, patients with poison, we give them our activated charcoal, so generally 1 gram per kilogram of body weight. So lastly, steps for Nepal. So Nepal, at this point, has a very rudimentary EMS system and is pretty much localized in Kathmandu. So the first thing you need to be able to do is have effective teaching programs. So my suggestion would probably be on the maybe even smaller than the district level. I don't know how big the districts are here, but probably smaller than the district level. You want to make sure that you have paramedics who are adequately trained in their professions who can actually go and teach. So the way we do it in the States is we have three different courses. So I took the accelerated course. It's just 3 weeks, Monday through Friday, 8 to 5. Within 3 weeks, you can learn everything about the EMS system. For students, there's also a weekend course, so 8 weeks, Friday and Saturday, 8 to 5, which might be better for students. And then the weekday course, Tuesday, Wednesday, and Thursday. So 4 hours every night, which might be a little harder for students to manage for school, but that's also another possibility. Also, we want to make sure that we nationalize the EMS. So right now it's very localized, but we want to make sure that we implement EMS on a very large scale. And also a national exam. So the National Highway Traffic Safety Administration implements this national exam that we take as EMTs in order to make sure that we're qualified, in order to become certified. So after the class, you want to make sure that you have some sort of national exam that everyone can take, generally at the same time. Make sure that they're ready to go. And also, you want to make sure that you integrate it into other healthcare systems. As the EMS system develops, we want to make sure that the hospitals know about it, and that local clinics and poison trauma centers also know about the EMS system. I know that I think Patan is doing something with Stanford students now, in which they're trying to implement teaching programs. So Stanford students will come here and they'll start teaching EMS. So I think that's a really good first step to take for Nepal, and hopefully in the future EMS will be like a nationwide thing and not just localized. So thank you.